And now, it's Boomer Life. Lifestyle discussion designed to make your life more engaging, meaningful, and complete. Celebrating the baby boomer generation, this is Boomer Life on CIL 650.
Well, good morning and welcome to Boomer Life here on CIL 650. Sterling Fox with you, joined on the line from Falls Creek Healthcare Center by Surgeon Dr. Charles Scudamore. Dr. Scudamore, welcome, sir, to Boomer Life.
Well, thank you very much, Tony.
It's good of you to join us. Let me just tell our listeners a little bit about you, sir, and then I'll ask some questions. But I know for a fact that you are a staff surgeon at Vancouver General. You're the director of the BC Liver Transplant Program. You are also an associate professor of surgery at UBC, in addition to being a general surgeon at Falls Creek Healthcare Center. A little bit more about yourself, Dr. Scudamore. You're a BC guy, yes?
Born here, fifth generation.
All right. UBC grad?
Yes.
And so coming back to home turf after going out and learning about the big bad world of medicine was pretty instinctive for you, I suspect.
I've practiced in 8 countries.
Really?
Yes.
And how long have you been back and now full-time in Vancouver and BC?
Oh, 25 years.
Okay. So what did the practice around the world in those 8 countries, what did that do for what you're doing now in Vancouver?
Well, no system's perfect, and nobody knows all the answers, and so you have to go and collect them yourself and bring them back.
Right.
And so that's what I did, and the specialty that I'm in really didn't exist when I started, so you have to sort of put it all together, and there's no one place to go to learn it all. And so that's why I had to do all these things. And besides, it was fun to go to these other places.
I'll just bet it was. What an exciting way to put together one's career. Now, I must say, just before we went on the air this morning, friends, talking with Dr. Scudamore, I mentioned that the name of the program that he was about to make an appearance on is called Boomer Life. And, Doc, you got pretty excited about that because, well, you a boomer, as am I, but you were just saying that more and more of us boomers are, well, we're sticking around a whole lot longer for openers, aren't we?
Well, as I say, medicine's trying to make life longer and better and alleviate symptoms and cure as many diseases as possible to keep us going. And just an example is that the age was 65, or almost everybody had to retire.
Yes.
Now they've lifted that, and so you're seeing these people continuing on contributing to society way beyond 65 and enjoying doing it. So I think that medicine has been hugely successful in promoting wellness and as well as longevity.
Right, and of course, as one ages, clearly there are perhaps more, shall we say, interventions required to prolong that longevity, but at least medicine has come up with those measures now, haven't they?
Indeed, and it makes it safer and better and smoother, and so therefore the risk of having procedures is way reduced. We
were talking before we went on, Dr. Scudamore and I, about the way surgery has changed in recent decades here. The priority nowadays, I suppose wherever practical, Dr. Scudamore, is a surgery after which there's not a lot of evidence left that one has had a surgical procedure, correct?
Well, that's the whole principle of minimally invasive or minimal access surgery, is that you want to reduce the discomfort and disability of the surgery itself by reducing the amount of tissue you have to cut through, making minimal scars, and so therefore the process is simpler and better and quicker, and the scarring after that is minimal. So those two things are what we are striving for.
Has the pressure to reduce the cosmetic scarring actually caused surgeons like yourself to perhaps even reinvent some techniques?
Well, it's interesting that nothing really is new under the sun. It's just a different approach to the same problem.
Sure, right.
And so, some of the, like, just for instance, like gallbladder surgery or hiatal hernia surgery, it was all done as open procedures, a few decades ago, and it made it impractical. Now that these procedures are done as daycare procedures virtually, then they can be done as daycare. They don't have to stay overnight in the hospital.
Right.
And the reason for that is not only is the discomfort minimal, it's also the risk factors of the surgery have been reduced so much.
Is it a good idea? I mean, obviously it is, because that's the way things are done now. They really do seem, wherever possible, Dr. Scudamore, once you've had that surgical procedure, they want you up on your feet and out and about as quickly as possible.
Yeah, no, I think that it's just like you see, a deer born in some sort of savanna place in Africa. If you're not walking right away, that some lion is after you.
Right,
and, And the same thing, that same principle. You go against nature at your own peril, and so therefore, by getting up and moving around, you reduce blood clots. You reduce the adhesions. You make sure that you can function, and you breathe better, so you don't get atelectasis of your lungs and things like that. So you do better. The only way you can do that, though, is you don't have terrible discomfort that is causing you to be bedridden. So therefore, the minimal access surgery is a huge advantage in that regard.
I can well imagine it is. Dr. Scudamore, I'd like to talk to you a little bit about general surgery. Now, I should also, before I go in this area, I should also, by way of informing our listeners exactly who it is they're listening to, I should also let our listeners know that you are a recent recipient of the Queen Elizabeth II Diamond Jubilee Medal, and also a recent investee into the Order of British Columbia. You enjoy a great deal of respect from your colleagues and fellow citizens here in BC. What is a general surgeon, Dr. Scudamore? You've alluded to your specialty, but what does a general surgeon do?
Well, general surgeon is an unfortunate term for the complex issues that they have to do. They do trauma surgery, they do cancer surgery, mainly to the GI tract, and so they do surgery of the alimentary tract, basically from the mouth to the anus. They do hernias, they do trauma to that area, and they do cancers in those areas as well. And so the complexity and the details of the surgery is far greater than one would expect as a general surgeon.
I was just going to say, a general surgeon almost sounds like a misnomer in this case, doesn't it, Dr. Scudamore? Because, in fact, it's quite a specialized area of activity that you're referring to.
Well, in fact, you're absolutely right. What's happened in surgery is that everybody's specialized off in different areas.
Sure.
And that's happened to the GI surgery. There's bariatric surgery, there's endocrine surgery, there's colorectal surgery, there's surgical oncology, there's trauma surgery, there's hepatobiliary surgery. They've all sort of gone into specialties, and rarely does a surgeon, even in small towns, they have specialties now. So it's really an archaic term.
Okay, but I'm curious, just as an observation comment, I'd appreciate, because as you pointed out, the era of specialization is very much upon us, and as you just said, even in smaller markets, you have very highly specialized medical practitioners. Do you sometimes hearken back for the older days where docs were a little more flexible in terms of the sort of general work each and every one of you could do?
Well, it's interesting you say that, because even cardiac surgery or vascular surgery, which used to require somebody to train for 5 years as a general surgeon and then do subspecialty, have started training vascular surgeons right off the bat.
Interesting.
And so, therefore, unfortunately, that person who's got the broad abilities are becoming very rare because of the nature of the specialty. You can't sort of start out your career at 35 years old any longer.
Right.
And so that's what's happening. It's the driving force to get people into their subspecialties earlier, at the expense of that broad aspect of surgery. But now with telemedicine and communication as it is, you can have a few experts around the province, and they can liaise with other surgeons. They can carry out the detail and decide who can do what, where, when, or who should be transferred.
Just a curiosity question at this point, sir. You talked about starting out your career. Back in the day when you were a med student at UBC, what area of the profession did you imagine yourself being drawn to initially?
I started as a plastic surgeon.
Oh, really?
Yes. So I decided the area that I found most interesting was impossible at that time. It was liver surgery and pancreas surgery. No one did it, and so therefore that's what I found fascinating. So I decided not to do plastics any longer and quit and did general surgery in a field that had not been developed yet.
And plastic surgery then, by the sounds of it, is a comparatively quite recent development then.
Well, plastic surgery is developing, like everything else. They're getting better, minimum scarring, outpatient surgery. Plastic surgery is not cosmetic surgery, just that. It's pediatric surgery that burns, they do trauma, they do very difficult malformations. A plastic surgeon does microvascular surgery. It's a tough specialty, and it's a broad specialty, and so, but it's basically does just superficial tissues and flaps and things. So it's quite a talent to do surgery, and there's subspecialties within plastic surgery.
Interesting. And now with the work that you're doing as the director of the BC Liver Transplant Program and doing surgery at both the Children's Hospital and VGH and Falls Creek, you're an awfully busy guy, and yet you still manage to find time to teach out at UBC. A pretty demanding schedule you have.
You have to ask my family about that.
All those people who used to be related to you.
That's right. Yeah, that's right. No, people only do what they want to do.
Right.
So if you're busy because you want to be.
Right, of course, of course. Talk to us about the types of general, and again, I'm using this term because it's presented to me as such, but the general surgical procedures available at Falls Creek Healthcare Center, Dr. Scudamore, would include what?
Well, the Falls Creek works very closely with the College of Physicians and Surgeons of British Columbia.
Okay.
And it's a hospital system outside the hospital system, so therefore they have to undergo all the regulatory procedures and standards that a regular hospital would have to do.
Of course.
And so they meet these standards and exceed them, and so therefore the college then licenses a private surgical facility to do certain procedures that they can do and are safe to do in that facility, and people wish them done. It's my feeling. And then I don't do lots of surgeries in these institutions, but I think if you really want to have something done, you should be allowed to do it.
Right.
And so therefore, the pain and suffering I described for the procedures, well, there's pain and suffering prior to the procedure.
Of course, yes.
And so if that's prolonged, that may be inconvenient and or not to the patient's advantage. And so therefore, if they wish to have somebody who they know and trust do a procedure in an institution that can do it quicker and more efficiently, then that's what they'll do.
And one of the things that your colleagues, and we've had the pleasure of speaking with several of your colleagues from Falls Creek Healthcare Center, they talk about the facilities, Dr. Scudamore, the actual operating rooms and the research facilities. You talked about being able to liaise with other medical professionals while you're actually performing surgery. And Falls Creek Healthcare Center has absolute state-of-the-art everything, don't they?
It's hard to keep up with everything.
Yes.
But they go way out of their way to make sure that the equipment they have is the latest and best available.
And you and others of your colleagues are, of course, really, and you've talked about having worked in 8 different countries, you enjoy connections, medical networks that really extend around the globe, don't you?
Indeed. I see patients from Montreal, for instance, and the United States and Hong Kong, and so there's no barriers other than the distances and time. We talk. We have in surgery we have live procedures now being filmed at meetings.
That's right.
They demonstrate a procedure, and they'll do it in front of 1,000 people.
That's highly amazing stuff, especially for those of us who don't get much of a glimpse behind the scenes. It's difficult to almost imagine that, but we certainly do have the opportunity to understand. I guess even medical television shows give us a clue, at least, Dr. Scudamore, as to the kind of technology just raging around the medical profession in 2015. It really is truly amazing.
Well, it's amazing. It truly is. I don't like I do liver transplants.
Yes.
And the commonest reason for liver transplant was hepatitis C 5 years ago.
Right.
In the last 2 years, we can cure Hep C, all of it, cure it.
That's amazing.
And so that whole indication for liver transplantation could be eliminated, relatively overnight.
That's spectacular, isn't it?
And so not only do you have to keep up with the surgical techniques, you have to keep up with the medicine that goes along with it.
Of course. Of course. Let me take a quick break. Our guest from Falls Creek Healthcare Center in Vancouver at 555 West 8th Avenue, I hasten to add, is Surgeon Dr. Charles Scudamore. And lots more still ahead. It's Boomer Life here on CIL 650. Nice to have you with us. Stick around. Lots more still ahead.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. Our guest from Falls Creek Healthcare Center in Vancouver is Surgeon Dr. Charles Scudamore, who is quite an amazing character, a UBC grad, been a surgeon for a long time, is just recently decorated with the Diamond Jubilee Medal, Order of British Columbia, teaches at UBC, director of the BC Liver Transplant Program, surgeon at BC Children's and VGH, and Falls Creek Healthcare Center. My gosh, Dr. Scudamore, this is probably almost an insulting question to ask you, sir, given the incredible qualifications you bring to the table. But I have to ask you about hernias. And I have to ask you, question number one is, what on earth is a hernia, and how do you fix it?
Well, first of all, there's nothing insulting in asking about hernias, because if you've got one, you don't want one.
Okay.
Okay. So
that part I do believe.
And the second thing is that hernia's got a reputation of coming back. So therefore, if it's done properly and well, the hernia doesn't come back and doesn't have complications, and you're a much happier individual.
Okay.
So I don't feel insulted about that at all.
All right.
The second thing is a hernia is an abnormal projection of the peritoneum through an abdominal wall. So normally we have a tough, fibrous lining inside our abdominal cavity called the transversalis fascia. And that transversalis fascia envelops the entire abdominal cavity and prevents hernias in the groin and hiatal hernias and abdominal wall hernias.
So sorry to interrupt, doctor, but is it safe then to say, just based on this limited description, that a hernia only occurs in a person in their abdominal cavity or around that area?
No, you can herniate anything.
Oh, really?
You can herniate abnormal projections going through someplace can herniate. Now, you can herniate in the brain, and it causes death. You can herniate. You get hernias in the colon. You get herniation of blood vessels.
Well, I was going to also suggest a herniated disc, which is what a friend of mine with back problems has.
And the herniated disc is exactly the same as abnormal projection of that disc into the cavity, the little canal that controls your spinal nerves.
So what causes these projections? Wherever it's sticking through where it shouldn't be sticking through, what causes the thing to do the sticking in the first place?
Well, there's usually a limiting membrane or coating or capsule around the... And you're going to talk about a disc. There's a capsule around the disc that keeps the disc, which is like a shock absorber, within the vertebral column itself.
Okay.
When that capsule breaks down, either from trauma, age, atrophy, use, trauma, that liquidy or semi-liquid fluid within that area is no longer contained and pushes out to the usually an aperture which is low resistance.
Okay.
Now nerves have to have an insulation around them. They need protection, and so they're not protected well as they come out through that spinal.
Oh, that's
so the hernia goes to the place that's least resistance, which happens to where the nerve's going through, and that squashes the nerve, and that's how you get that severe sciatic pain.
Ah, and what is, you mentioned it earlier, and I have to just ask you because I've heard this all my life and have no clue what it is. What is a hiatus hernia?
Now, hiatus is where, the body's made up of a lot of tubes. that have to connect to the rest of the other parts of the body.
Okay.
And so we eat with our mouths. It has to go through the thorax to get into the abdomen.
All right.
Well, there's the diaphragms, which are essential for breathing. You've got to get the food through into the stomach, which is below the diaphragm.
Right.
And so the esophagus is about 35, 37 centimeters in length, and it goes down through the musculature of the hiatus. And that muscular hiatus weaves around the esophagus to prevent the stomach and food and everything else from going back up into the esophagus. It's sort of a one-way route.
Sure, yeah.
Vomit, right?
Right, yeah.
Okay, so what happens is over time, we get our muscles become lax, and we tend to gain weight, and we valsalva a lot, meaning like we strain against lifting things.
Mm-hmm.
You tend to weaken that area, and so the hilar hernia is the transversalis fascia that keeps your stomach and your esophagus down below the diaphragm, weakens, and all of a sudden it moves up into the mediastinum, or the part between the two lungs. And that's how you get hernia. Now, once that occurs, you tend to reflux, and that means the food and your acid within your stomach goes up your esophagus.
All right.
And that causes symptoms of reflux, and that's a problem.
So now you've described actually, and thank you for your patience with this, you've described several types of hernias already. Are all of them equally available to be remediated through a surgical procedure, or are some treatable with drugs or other methods?
Well, let's talk about the hilar hernia.
Okay.
Okay. The problem with the hilar hernia generally is it's not the hernia itself, because they tend to be axial. I mean, it's still in line with the esophagus. It's the result of the hernia and the incompetence of the lower pincher mechanism to keep the food below the diaphragm.
Oh, so it's the damage the hernia has done.
Well, it's the fact that if the food goes up and the acid goes up in the esophagus, it burns the esophagus.
Sure, yeah.
Or it could even go worse. It goes into your sinuses, causing chronic sinusitis, and it can go into your lungs and cause a chronic cough and bronchitis. We don't want acid and food in the wrong place.
Right.
And so if they've got medicines now that reduce the acid and promote the peristalsis, that activity to strip the esophagus of food and acid and keep it down below, and that's medicine, and those things we treat with medicine initially.
Okay.
And if we can keep everything under control initially without any complications of the esophageal reflux, then that's usually sufficient. We don't tend to want to do surgery in those cases. However, in children, sometimes you have to fix it because it's going to be a lifelong risk. And in adults who begin to get complications of the reflux, like bronchitis or sinusitis, or maybe they get inflammation of the esophagus that it's not going away, then you really have to think about alternatives than medicine. Sometimes the cost of medicine is prohibitive as well, and patients can't afford lifelong medicines.
Okay, so by and large, though, it sounds like surgery is it safe to say, is the usual remedy for people with hernia issues?
I would say it is an alternative to the medical management.
Okay.
So if you have failure of medical management, surgery is an option. Or if you've got such a severe situation that surgery really is an option, it should be done earlier than it's done earlier.
Okay, now, Dr. Scudamore, you and I both are self-identified now as boomers here on Boomer Life on the radio. So is this whole hernia thing, is it a function of aging? Is it likely that as we get older, we're more susceptible to getting a hernia?
Absolutely. And there's a rule of thumb. The chance of getting a hilar hernia is exactly the same percentage of your age. So if you're 50, it's 50%.
Interesting.
If you're 70, it's 70%. If we all live to 100, well, you know what's going to happen.
Well, okay. So what can are there suggestions or tips that you might be able to offer us boomers that will things to do in our lives, perhaps in our diets or whatever, to avoid or to decrease the likelihood of a hernia?
Okay. Well, there's two things. One is you reduce the risk of actually developing a hernia, and that's keeping yourself fit.
Okay.
And so muscle strength and fitness, your core fitness, it definitely helps with herniations because the muscles are part of the way you prevent a hernia. That's number one. The other one is keeping slim. The more weight, the more intra-abdominal pressure you have, and that forces pressure on the hiatus, and that causes worse hiatal hernia and worse reflux. Now,
okay.
Apart from that, things like alcohol and things that make your esophagus worse, and things that eating at night, your stomach goes to sleep at night.
Yeah.
And so therefore, if you eat a meal late at night, you tend to go to sleep, and you've got fluid and food in your stomach, and that tends to reflux too.
Okay.
So, all the things that we should be doing should be, keeping fit, keeping our weight down, and not eating large meals late at night, and keeping things like aspirin and alcohol to a minimum for your reflux is probably a good idea.
Okay. So again, it's a lot of this is just practical stuff, isn't it? It's just paying attention to details, isn't it?
It is, yeah.
Is there, you mentioned earlier when I asked you my rudimentary question, what's a hernia and how do you fix it? You said, well, first of all, if you have a hernia, you know immediately you don't want it. So what's the worst type? Is there a worst type of, you really don't want to get that kind of hernia?
Well, the worst type of herniation, if you want to, this is herniation of your brain.
Oh, you mentioned that earlier.
That's a lethal hernia, and that because of your brain is in a finite box. You're called your skull.
Sure.
And the foramen magnum is that big hole where your spinal cord exits. And so if your brain swells up, it forces the important parts of your brain, the brain stem, down that foramen, which causes obstruction and causes your immediate death.
Yeah. Well, are there other types of hernias that are potentially as fatal?
Yeah, something, you're entirely correct. I think that's takes the cake. But the danger of the hernia is what's in it, and if it's so long as it's just empty and or has a little bit of fat in it, it's probably okay. It's just an inconvenience.
Right. Okay.
When you get a loop of bowel or something else in your GI tract stuck in that hernia, then you get a bowel obstruction, and that bowel can actually be pinched off and die, and so it can cause actual leakage of the intestine into the peritoneal cavity, which is a serious life-threatening event. So that's really the reason why you want to get some of these hernias fixed, because of the potential for that happening. And those hernias are generally small opening hernias,
right?
Not great big large hernias.
How do we know when we've got a hernia, or is it, whoa, I've got something that I've not had before, I better get it checked out? Is it that immediately obvious that something's wrong here?
Yeah, let's talk about groin hernias.
Okay.
There's 3 or 4 types of groin hernias. Basically, there's a direct, indirect, and a femoral type of a groin hernia. Then there's some complicated ones which I won't discuss. But those 3 hernias tend to have small openings in the beginning. And what happens is that there's generally a failure of something to withstand the onset of the pressure within the abdominal cavity, and that breaks down, and you sometimes feel a tearing or a burning sensation in the groin.
Okay.
And it often happens if you're trying to lift your trailer hitch off the back of the ball. I could do this.
And then all of a sudden you feel a pop.
And then all of a sudden you take a big breath in, you hold your breath, and you go, great, that as you lift, and that huge intra-abdominal pressure will force that hernia to go open.
Oh boy.
And so that's why weightlifters breathe out when they lift.
Oh, okay.
Just a practical solution.
And they always wear those big belts. Is that part of the package too?
Well, I think the big belts are to support their back.
Oh, okay.
Than their hernias, but there are belts that for hernias too. They don't work all that well sometimes, and they're pretty uncomfortable. But you can wear them, yes.
So it's possible then, just for an unfit person to try to take on too much of a physical challenge, and that could very possibly result in a hernia situation.
Well, I wouldn't just say unfit. It can happen to anybody, unfortunately.
Okay.
And and so what happens is that for whatever reason you may have some congenital, i.e. present at birth risk factor,
okay,
that only presents itself later in life. So it's not really your fault. It's just that it took a long time for it to be manifest.
Right.
But then But if we are not fit and we don't, we've got muscles that are not well toned and we've got carrying too much weight on the abdomen, those are all risk factors for hernia. Sometimes, though, you get prostate problems and you're forcing, and that can cause a hernia as well.
Interesting stuff. Dr. Scudamore, I need to take a quick break, sir. And when we come back, I'm going to draw upon your expertise and talk a little about laparoscopic surgery, if you're good with that.
Sure.
Our guest is Dr. Charles Scudamore from Falls Creek Healthcare Center at 555 West 8th Avenue in Vancouver and online at fallscreekhealthcare.com. This is Boomer Life on CIL 650. Lots more still to come.
Canada's only weekly radio show dedicated to the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. A real pleasure to have one of British Columbia's foremost surgeons, Dr. Charles Scudamore, as our guest. Dr. Scudamore from Falls Creek Healthcare Center on the line very, very patiently, and God bless you for it, Dr. Scudamore, for the patience you're exhibiting with me and my questions about surgery and surgical procedures. We all watch too much television. Those doctor shows are awfully darned entertaining, But we all, as a result of that, think we know more about medicine and what goes on in the medical profession than we actually do. So when we have a chance to speak to a real doctor, we're kind of overwhelmed with questions. So I do appreciate your patience. We mentioned we were going to talk about laparoscopic surgery in this segment. What is that?
That's minimal access surgery. You generally go through a portion of the abdomen or through the GI tract to identify the abnormality within the peritoneal cavity and fix it by television, by remote techniques.
Okay.
Long, thin instruments, and you use the television within the peritoneal cavity, so the camera is right at the end of the scope.
So you're actually, as the surgeon performing the procedure, you're looking at a television screen while this procedure is underway.
Well, we all watch too much TV.
I guess you do, but no commercials, mercifully for you, while you're working at least.
That's true. No, it's actually a huge advantage to do it that way because you can actually see the entire peritoneal cavity laparoscopically.
Okay.
And you can change the attitude of the cameras, and it's really an amazing thing. Through an incision, you can't actually see or do things in some parts of the abdominal cavity because you just don't have access to that.
Sure.
So it's got some distinct advantages.
So now we were talking about hernias, and a lot of which are related to the abdominal cavity. So does this procedure, in some cases, apply to hernia surgeries?
Indeed, it does. The three types of hernias that it applies to is that groin hernias, ventral hernias, and the hiatal hernias.
Okay.
And so if we can just talk about ventral hernias first of all. The ventral means it's a hernia in the wall of the abdomen surrounded by your tummy button. And it's very common to have it after an open surgical procedure or even a laparoscopic procedure, which has left a little gap sometimes.
Okay.
And what you need to do is you have to identify the hernia, and you can actually see it very easily, and the light from within the abdomen can actually shine through the hernia. You can see it from the outside, too. And the advantage of that is you can actually see the hernia and put the mesh to repair the hernia on the inside of the abdomen rather than the outside. So therefore, any increased intra-abdominal pressure, which I was mentioning that causes the hernia in the first place, is pushing against the mesh rather than pushing a hole covered by the mesh. And it covers the actual defect, so therefore bowel and omentum and things like fat getting into the hernia is much less.
And how is the mesh that keeps this hernia then from breaking through? How is it installed, for lack of a better surgical verb?
Well, it's done by two ways. First of all, you take sutures that go through the abdominal wall and place the mesh over the hernia in an accurate location. These are sort of like guy wires.
Right, yeah.
And if you were thinking of putting up a tent or an awning, you pull them on the four corners to get it nice and flat and over the right spot. And that's what you do. You just pull these guy wires and get it over the defect. And then with absorbable tacks, you tack the mesh onto the abdominal wall from behind. And over a period of time when these tacks dissolve, the mesh incorporates into the abdominal wall, and therefore it prevents another hernia.
So these mesh bits that you install don't need to be replaced every 2 years or anything like that. Once in, it's done, right?
Well, there's several types of mesh. The major problem with mesh is that it causes adhesions, And if you get abdominal wall, hernia defect controlled, you don't want anything sticking to the back side of the mesh, and that's been a technical issue for years. And they've got new meshes that don't adhere to the bowel, and so therefore that reduces that risk significantly. The other thing you want to make sure is that bowel or omentum don't get around the mesh, so you have to make sure the mesh is well tacked down so something can sneak through one of those defects.
Interesting stuff. Dr. Scudamore, when people come to Falls Creek Healthcare Center and present with these hernia difficulties, what is the most common type you're likely to see day to day?
Groin hernias are the most. It is a design flaw in our anatomy. Because we walk around erect, we do have some definite organs that have to pass through the abdominal wall, and so in order for that to happen, you have to have a defect in the abdominal wall, and those defects turn into hernias.
Okay. I wanted to talk in the context of laparoscopic surgery, which is where we're at right now. I wanted to include the word gallbladder after laparoscopic surgery. Is that a fairly common procedure?
Almost exclusively gallbladder surgery is done laparoscopically now.
Okay.
And the reason why you wouldn't want to do it laparoscopically, you've got a high risk of bleeding, such as chronic liver disease, or there's a risk of a cancer in the gallbladder. Gallbladder surgery, 100 cases a year in the province have a potential tumor of the gallbladder, and that one you may want to approach as an open procedure if there's a high likelihood of a cancer, because laparoscopic surgery in that situation is not a good idea.
So we hear, of course, of terribly, terribly painful gallstones, which affect some individuals. Is that why ultimately gallbladder surgery is required, because it continues to produce these gallstones, which, of course, are painful to say the very least?
Well, gallbladder stones may or may not be symptomatic.
Interesting.
If they're not symptomatic, they don't seem to bother you. You don't have to bother with them. They don't generally cause problems, and you're okay. Just the fact that you have gallstones does not mean you have to have your gallbladder out.
Oh.
It's when they become complicated. They start moving around. They start obstructing the gallbladder. They start going down the common duct. Then you have problems, and that's when you start dealing with them. And yes, you're right. It can be extremely painful and last a long time, too, hours of agony. So, you don't have too many gallbladder attacks before you're interested in some surgery.
I'll just bet that's true. You mentioned in the context of explaining some hernia issues a few minutes ago, Dr. Scudamore, you talked about prostate issues, and you're a surgeon who does perform a lot of cancer surgeries, and I would assume that prostate cancer is one of the types that crosses your operating table from time to time.
Well, I never do prostate surgery. That's done by urologists.
Oh, really?
But there's lots of cross-pollination within urology. Some cancers of the kidney and other things. So I work closely with urologists, and so and I have the greatest respect for them, and they tend to be very specialized as well. But anything that increases your intra-abdominal pressure. So if you have prostate or you're chronically constipated or something, you tend to have to force the issue, and that predisposes you to herniation.
Okay, I wasn't aware of the fact that it was only a urologist who would operate on the prostate. But then again, that's that era of ultra specialization we discussed at the beginning of the show.
Absolutely.
That is interesting stuff. But in terms of back to the laparoscopic gallbladder surgery, is there a biopsy that is required before any surgical procedure, or is it just about gallbladders?
Biopsies are very interesting. They're very important in certain situations, and very unnecessary, and even contraindicated in certain situations. In the good old days, you never took out a tumor without a biopsy. Nowadays, we often take out tumors because we can make the diagnosis without a biopsy.
And that's just the better quality of diagnostic tools you have available.
Exactly. And
okay.
So you got much more detail with imaging like CT and or MRI,
right,
and endoscopic ultrasound, and all these are much more accurate than they used to be in the good old days. And so we have to be very careful and selective on who we biopsy these days. And interesting enough, liver disease in order to diagnose liver disease. Yes, sometimes you have to do a biopsy, but oftentimes we can do it on a FibroScan or just detect the density of the liver and find out what the disease process is without a biopsy. And now that we're curing all the hepatitis B and C's, then this is less necessary these days. So when you do need one, you need one, and it's got to be done accurately and well. And if you don't need one, you shouldn't have one. And some tumors, you don't want a biopsy.
Interesting. And by the way, we need to take a quick break here. But speaking of, if you don't need it, you shouldn't have it. Is the appendix still something that basically we should all live with unless there's some really good reason to have it removed?
Do you know something? I can answer that quickly. We used to think that the appendix was a vestigial organ, i.e. not necessary, not modern.
Yeah.
Not true. The appendix, nature always does. Nature never makes a mistake, and so it's only had a couple of 100 million years to get it right.
Okay.
So I think it's arrogant on our parts to think that for a few short years of education you can outsmart nature. So what happens is the appendix is a reservoir of special bacteria. So if you get some sort of infectious diarrhea, that you can repopulate your colon with those bacteria.
So it's not as useless as we have been led to believe.
Very few things are useless.
Interesting stuff. Well, I love the analogy of after only a few decades of medical education, we decide to upset 200 million years of evolution. Aren't we pushy, huh?
That's right.
Our guest is Dr. Charles Scudamore from Falls Creek Healthcare Center. This is Boomer Life on CIL 650, and we're back with our final segment in just a few moments.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. I'm Sterling Fox, joined on the line by Dr. Charles Scudamore from Falls Creek Healthcare Center here in Vancouver, talking about, all of the areas of surgical activity that Dr. Scudamore has been involved in for his entire career. He is, in addition to being a surgeon at Falls Creek, he also performs surgeries at BC Children's Hospital. He is the director of the BC Liver Transplant Program. He works at Vancouver General Hospital and teaches out at UBC in the Department of Medicine, in the Faculty of Medicine, and Department of Surgery. Dr. Scudamore, we were talking about laparoscopic surgeries, and you said this is one of those innovative or newer techniques that are, first of all, most importantly, minimally invasive, and yet absolutely astonishing with respect to the amount of information inside a person that laparoscopic investigation is capable of producing.
Well, that's exactly right, Sterling. The issues with minimally invasive surgery is you just want to get by the abdominal wall, that mysterious barrier to everything that's inside. And nature wants to protect all the vital organs, and so it doesn't make that easily accessible for people. And so with new imaging studies and with laparoscopic direct access, you can go in and look at the tumors right up close. You can do ultrasound, and the cameras are all end of the instruments, and you can get right to the area of interest and decide how big is it, whether it's important, is it dangerous or not, and to what extent it has spread.
And we talked about biopsies earlier, and you informed us that they aren't as mandatory as they were once certainly treated as and thought to be, but would a laparoscopic investigation allow you, the surgeon, to determine whether a biopsy would even be needed in these circumstances?
Indeed, and the appropriateness of the biopsy. Now, we don't, in certain areas, we don't need a biopsy for the diagnosis any longer.
Right.
What we need is biopsies for staging and differentiation. Has it spread too far, yes or no? And that's important. And so biopsies of things that we don't understand or we can't investigate any further can be done safer laparoscopically, because the danger about the biopsy percutaneously, i.e. through the abdominal wall, is that it may spread the tumor if you have a tumor, or it may bleed if you don't have a structure that can control bleeding. And so laparoscopic tends to be a safer way of doing that.
Interesting stuff. So now, would you be able to, I'm curious as to the process in diagnosing. You were talking about a tumor. Suppose someone has some kind of tumor in their abdomen. Now, you were talking about going in with the camera, the laparoscopic investigation. Would that be the first way that you would investigate whether a person has a tumor in their abdomen, or would there be an X-ray or some other diagnostic approach first before going in?
Well, you're entirely correct. What you would generally start generally, and you hone down into the actual diagnosis and treatment.
Okay.
And so you often go through several sophisticated imaging studies first, and some biochemical studies on your body fluids and things of that nature to find out what we're looking at and is this dangerous or not. Now, right before a big operation or even an alternative to an operation, a laparoscopy may be indicated. Not 100%. Sometimes it's very important to have it done because of certain sub-imageable lesions. Sub-image means even though we're sophisticated with CT and MRI, you miss 10 or 15% of tumors in certain situations, or misstage them. And laparoscopy is a contributing way of making sure that the staging is correct.
As a surgeon, you must just be so thrilled with the availability of that laparoscopic diagnostic tool, so readily available, so frequently for you.
It's a useful tool. It's not it's not done for everything, but it's done for certain things. And let's to give you an example. If you happen to have an inappropriate operation, i.e., you can't take the tumor out,
right,
and there's no advantage to having the operation by bypassing something, you now have to heal up from that operation to take the alternative therapy, and that takes at least 6 to 8 weeks, a couple of months before you can actually have the right treatment. So that can be avoided by a simple day care procedure. That's a big advantage.
Take 8 weeks out of the schedule and turn it into 8 hours, and that's a big difference.
Absolutely.
You mentioned something, and I just need to go back to this. We were talking about liver issues, and you, of course, are the director of the BC Liver Transplant Program. But you mentioned at the beginning of the program something you almost kind of casually threw it away, and I'm still kind of agog at the fact that I did not know until this conversation began a short while ago that we, as in society in 2015, no longer have to live with hepatitis C. We can fix that now. We can cure that. That's amazing. And it's been that way for how many years? 2 or 3?
Just recently, and the drugs are coming out just now, and it's just been approved. We've been able to cure or control Hep B for the last more than a decade. But 20 years ago, you could not have a transplant if you had hepatitis B.
Right.
But we've got several treatments for hepatitis B now that control the virus so that it no longer is an issue, and you can live very long, have transplants with hepatitis B. Only recently, however, have been able to really reliably treat hepatitis C. And in the last few years, for most types of hep C, we get a 98 or a 99% cure rate for hepatitis C.
That's remarkable.
Now, I must emphasize one thing, however. It's not a vaccine. You cure the hepatitis C, you can still get it again.
Oh, really?
Yeah, so it's not a vaccine. So therefore, the controversy is if you cure hepatitis C, and it's quite expensive, what happens when you get it again?
Aha. Well, and that's one of those medical/ethical discussions that is likely to go on for quite some time, isn't it?
Yeah, absolutely. That's a very interesting situation developing.
You were talking earlier about some of the cancer surgeries that you do performed, and I had talked about prostate cancer, and you said, no, well, those are typically done by urologists, but I work closely with them all of the time. And I suppose that must be one of the real fun aspects for a fellow like yourself, as advanced in your career and in your profession as you are, to be able to go to work at a place like Falls Creek Healthcare Center, and all of those colleagues, Dr. Scudamore, all of those experts under one roof. You can walk down the hallway and have conversations about a patient of yours with any one of a number of people eminently qualified to help you out.
This depends on which floor you're on, who you want to talk to. You're absolutely right. It's great talking to other people, and I actually learn a great deal from my colleagues, especially those people who are not in my surgical specialty. So I learn from radiologists, and I learn from gastroenterologists, and I learn from urologists. I learn from everybody else, and those techniques we can cross-pollinate. Say, gee, that's a good idea. Why don't we try it here? And we do.
So is it I suppose medicine and science in a larger context is something one always has to be prepared to discover with. So I'm sure that you're always kind of looking for a kind of a new angle, a new way, a new method of doing this or advancing that. And surrounded by knowledgeable colleagues can only make those things happen faster.
Absolutely correct.
Interesting stuff. So if you were if you had a wish list that you could have fulfilled with the colleagues that you have available at Falls Creek Healthcare Center, what would be, if we managed to cure Hep C in the last 2 or 3 years, what would you like to see us or you and your colleagues be able to eliminate or certainly make huge advances on in the next 2 or 3 years?
Waiting lists.
Oh, okay. Well, you're going to get a unanimous round of applause for that one. Nobody in British Columbia is going to fight you on that one.
Okay. That's unfortunately that's the big thing now. It's I don't think any society can afford health care.
Right. So in terms of specific techniques, and you again, and I hate to use a bad pun, but as doing the sort of work you do, you literally are at the cutting edge of surgical advancement. And is there anything in your specific area of surgery that you really like to make that next step to and accomplish?
Well, I think that we have to stratify things, and so therefore things that can be done laparoscopically or outpatients, we should focus on those and eliminate those lists, and so it frees up the bigger, more complex hospital beds and operating rooms for the transplants and the big cancer surgery. So therefore, what we have to do is make sure we stratified healthcare, really well, so that people with bad things don't have to wait.
Right.
People who have elective things can choose at their own whether they should get it done quickly or not.
Right. Well, so without compromising anyone's well-being, the whole process in many cases can actually be speeded up, can't it?
I think so. I mean, it's a huge process. It occupies a very large segment of our society's activities, health, and at all levels, and right from prevention, well-baby clinics, all the way up to management of people who are in nursing homes.
And it's certainly one of the reasons Falls Creek Healthcare Center is becoming ever so more popular as time goes on.
Well, I think that, everything becomes more efficient and therefore more affordable and therefore more accessible to more people.
Dr. Scudamore, a real pleasure to have you on Boomer Life with us this morning, sir. An absolute joy to have a conversation with you. I must tell you, I hope our listeners feel as they've learned as much as I have in the last hour. It's been quite an eye-opener.
Well, thank you very much, Sterling.
My pleasure.
Bye now.
Bye-bye. And we'll see you next time right here on Boomer Life.